pneumonia, presumably. The point, general points. One, in the developing world, it's common, especially for community health workers and others who may not have the same level of training as you, to use syndromic diagnosis and treatment of pneumonia, i.e. fever plus tachypnea equals pneumonia equals antibiotic. We'll talk about that a little bit more at the end of the talk. There's a lot of effort going on right now to expand access to preventive vaccinations, both pneumococcal vaccination, Hib vaccine, and also to reduce indoor exposure to cooking fire smoke. And so if you ever want to go into a unique niche in the global health field, you can become a stove expert and help prevent all the secondary smoke exposure that sort of contributes to respiratory tract infections. So some of the things that are key differences that I will point out is that differences in standard of care and duration of treatment. And certainly in the US practice, we've seen our own sort of swings of, do we give cephalosporin versus penicillin-based treatment of pneumonia, duration of therapy swings back and forth. But in this context, I just want to orient you to practice standards. So for children under the age of 2 months, think neonatal sepsis workup and neonatal sepsis pathogens, to include, standard things like pneumococcus, but also GBS and E. coli, which could present with pneumonia. The recommendation would be combination beta-lactam plus aminoglycoside for 10 days. For older children, it's really driven by, again, something called danger signs that we'll talk about at the end of the talk. How severe is the infection? Essentially inpatient versus outpatient management. But note that, the duration of therapy that we're typically talking about is generally 5 days, but certainly 10 days or less, even for severe disease. And the idea here, this is driven both by some efficacy data, a recognition of the low precision of guesstimating what the offending organism is, in most cases of lower respiratory tract infection, and a cost-benefit resource management decision that most ministries of health and the WHO take into consideration when they're putting forth practice guidelines for use in a low resource setting. Some other common respiratory tract infections, and again, just note the durations here that the WHO recommends. So otitis media, 5 days. Chronic otitis media, quinolone otic drops for 2 weeks. So this is sort of a pet peeve of mine. I guarantee you that some of you who've already done at some point in your career MedCaps and MedReadies probably had an aminoglycoside based otic drop, dexamethasone plus an aminoglycoside, and that's all you stop. And chronic draining ears are extremely common. And so that aminoglycoside-based otic drop is fine if you've got swimmer's ear. It is not fine if you have a tympanic membrane perforation and a chronic draining ear, and now you're going to pour an aminoglycoside in there, right? So again, if you're the person who's making decisions about what goes into the sets and kits, it should be a quinolone otic because you won't make a child deaf. And then I'll also just point out again, duration of therapy for mastoiditis, 10 days of therapy is what's recommended. That's significantly lower than often occurs here in the United States. And again, that's sort of a judgment call, sort of balancing risk-benefit and cost. All right, so moving on to meningitis. So these are some of the stats that give you a sense of sort of the burden associated with Streptococcus pneumonia. It's worth noting that this burden of disease associated with strep pneumo infection, not only from meningitis, but severe bacteremia and severe pneumonia, has also declined as we've expanded access to strep pneumo vaccine. And we're seeing similar trends for Neisseria meningitidis and also Haemophilus influenza. So as a reminder, all of you sort of know basic signs and symptoms of meningitis, but I'll, as a reminder, point out that children under the age of 1 who have open fontanelles often lack those classic meningeal signs, and so that's where the distinction that pediatricians make between being fussy versus irritable comes into play. That's a judgment call that takes a lot of experience looking at kids, and so my advice to you is, if in doubt and you're not sure, you need to either tap the kid or empirically treat them for meningitis. And that's, I guess really all we can really say about that. Because relying on a bulging fontanelle to help determine whether or not a child has meningitis really means that you've let the disease get out of control. And the reality is, if you don't have, if you didn't bring your own lumbar puncture kit, most health facilities in the developing world at the sort of sub-district level are going to have limited access to LP kits, LP needles, and the ability to do much microbiome, and certainly limited ability to do anything microbiologically other than, is the fluid cloudy or not? All right, differential diagnosis of acute meningitis, right? So here's the long laundry list of all the things that can give you a meningitis. Clearly, we're not going to talk about all of them. A couple notes here about mimics. So tetanus, both neonatal tetanus or tetanus in an older person, especially if it gives you opisthotonus, could mimic meningitis. Mental status is going to be preserved. So especially in a verbal, child or adult, they'll be able to communicate with you. But in neonatal tetanus, might be very difficult to distinguish. Absence of fever would be another feature. Cerebral malaria, also a mimic of meningitis. Classically, the description is that people with cerebral malaria won't have evidence of nuchal rigidity. You will often see retinal findings, or retinal hemorrhages, or other retinal changes that Dr. Miller will likely talk about. And if you do a lumbar puncture on them, CSF will be clear. And then I'll just point out that TB and cryptococcal meningitis are especially problematic in areas of high HIV prevalence. Those illnesses certainly eventually look like acute bacterial meningitis, but there's often a history of a chronic smoldering illness that's sort of gone on for days or weeks before the patient sort of falls off the table and abruptly decompensates. And that clearly needs targeted diagnostics or therapeutic approach. So strep pneumo, traditionally considered the most common cause of bacterial meningitis, all comers. Again, there's been marked reduction as Prevnar has been rolled out in many African and Asian countries. I'll just note that we worry a lot about penicillin resistance here in the United States and in Europe. There is limited surveillance data on penicillin resistance in Africa and Asia, but it's generally felt to be infrequent. And so ampicillin, penicillin would still be commonly employed therapies in these settings. Just want to show you, so this is where pneumococcal vaccines are now part of the national program. So good coverage in Central and South America, beginning to be rolled out in Africa, but still a lot more work to be done, and limited progress throughout much of Asia. This is the most recent map I was able to find. So moving on, Haemophilus influenza. So Haemophilus influenza type B has essentially been eradicated in the United States through a very effective vaccination program. In areas where this vaccine is not used, this is still a major cause of morbidity and mortality in children under the age of 5. Of note, even if you have access to culture from the CSF, If the lab that you're sending your sample to doesn't have chocolate agar, which essentially is a specialty agar, right? So most labs in the resource limited setting, if they're doing a culture, they're going to have blood agar. So standard blood agar, Haemophilus influenza is not going to grow on, so you need specialized media for it to grow. Commonly produces beta-lactamases, so third-generation cephalosporins would be indicated. For this reason, I will argue that if you're talking about meningitis in a child under the age of 5, ceftriaxone or a comparable third-generation cephalosporin is your drug of choice, because it will be hard to distinguish between strep pneumo and Haemophilus influenza. I'll also point out that Haemophilus influenza is associated with high rates of bacteremia and secondary infections. And so this is everything from epiglottitis, orbital cellulitis, pneumonia, buccal cellulitis, which, you know, if you put your hand inside this child's mouth, this would be firm, woody, indurated swelling. There's probably something else going on with this kid's eye as well, and septic arthritis. And so that's a cautionary note to remember that Haemophilus influenza child may present with one of these features, which is sort of the distracting injury from the fact that, oh, by the way, they also have a blossoming meningitis, or vice versa. So keep that in mind, because these sort of focal infections often occur in combination. So where has Hib vaccine been rolled out? Again, good coverage throughout Central and South America, limited uptake throughout some parts of South and Southeast Asia, and kind of emerging coverage. This light green is less than 80% coverage. So, you know, there's programs at work here. And this is probably in part due to the fact that Hib vaccine is probably less expensive on a per unit dose and has a fewer total number of doses required than pneumococcal vaccination. All right, meningococcus. So in the tropical medicine context, the main thing to think about for meningococcal infection is the sub-Saharan African meningitis belt. We think, 13 different serogroups that can cause it. A, B, C, Y, and W135 are typically the most important epidemiologically. The vaccine that is in common practice in the US military is A, C, Y, and W135. There is a B vaccine on the market, but it's not routinely given except in a known outbreak setting. In clinical manifestations of meningococcus, right? So this is a child with fulminant meningococcemia, purpura fulminans. Certainly high risk of mortality. If the child survives, this level of tissue necrosis likely to result in severe scarring requiring skin grafting, and often results in amputation of digits or limbs. But this is also meningococcemia, and probably a more common sort of starting point of what someone with a meningococcal rash and these scattered petechiae might look like, right? And so that's a very different clinical spectrum that you need to be on the lookout for, and realize that, you know, the progression of illness from this to that prior slide can occur relatively rapidly. And it's sort of one of the big challenges with seeing, seeing patients like this. I would also note that patients with purpura fulminans, or very sort of acute meningococcemia, often have a sterile CSF, and essentially the disease is just moving so fast that if you don't treat them, they're going to be dead before the time they're able to see their CSF and have a culture grow. So that's one of the good things about meningococcal infection is that if you catch it early in the illness and intervene with therapeutics, it's a very exquisitely sensitive organism. Single doses of antibiotics typically will sterilize the cerebrospinal fluid. And so this is really one of those conditions where time to antibiotic really will matter most. In the sub-Saharan African meningitis belt, right? So the Sahel region that extends throughout West and Central Africa, and then with slightly different seasonal variation into East Africa. Historically, it was quite common during the dry season to see large outbreaks of meningococcal infection. And there'd be peaks and valleys, you know, in terms of the burden of disease from one year to the next. In the late 2000s, a meningococcal A conjugate vaccine, comparable to the one that we currently use in our own population, was developed. This meninge A only vaccine was shelf stable without the need for a cold chain, and was cheap enough that it could be delivered at scale to large populations. And so we shifted from an approach of reactionary epidemic response with a suboptimal polysaccharide vaccine that was less effective, especially in young children, to a protein conjugate vaccine that induces long-lasting, highly effective immune response. And so we've shifted from outbreak response to preventive therapy, and the burden of meninge A, which is the predominant serotype in Africa, has dropped precipitously. Certainly, I think there's an outbreak going on right now, I want to say in Nigeria, and perhaps elsewhere in West Africa, where it's noted that some other non-A serotypes are being recognized. So that doesn't diminish the overall sort of public health benefit that meninge A vaccinations have. And I guess we'll have to wait and see whether or not that's just periodic blips of non-A, or whether we see serotype replacement and ultimately a polyvalent vaccine approach is required.
So, on that, so just kind of looking at the graph, looking at like 10,000 cases in 14 to 80 in 16.
Yeah. Yeah, that's the WHO stat. Now, we'll say, right, that's also confirmed cases that got a spinal tap and a lab diagnosis.
Got it.
So, right,
Okay.
so any epidemiology out of, I think Africa in particular needs to be taken with a grain of salt when it comes to confirmatory diagnosis. But clearly the large outbreaks of meninge A that we're being seen year after year have not persisted. And I think that's really the main takeaway. All right, so the question is, what do you do when you see a patient who you suspect has meningitis, or you know has meningitis because you were able to do an LP, but you have limited access to confirmatory cultures? So the WHO recommendation for children under the age of 2 months, again, think about neonatal sepsis causes that include gram-negatives. So ampingent or ceftriaxone-ingent is recommended. Older preschool-age children, slightly different microbiology, but pneumococcus and Hib predominate. And so ceftriaxone and then ampicillin as a second line would be recommended. Older children and adults, you're primarily talking about pneumococcus and meningococcus. So again, ceftriaxone and ampicillin is what's recommended. And again, duration of therapy is a little bit less than we would typically think in terms of a parenteral approach. And this is again driven very much by resource expectations. In an outbreak setting, so you know you are dealing with an outbreak of meningococcus that has a very specific definition by the WHO standards. Once you've made a microbiologically confirmed, serologically confirmed case, you can shift from doing LPs to syndromic diagnosis. And especially if you're in a resource-limited setting, the recommendation would include for children over the age of 2, single-dose ceftriaxone is an acceptable standard of care. Again, because the rate at which you sterilize the CSF is so rapid that there's good evidence to support that approach. The idea is in younger children, because of all the other organisms that might be at play, you would still act conservatively and give them 7 days of treatment. With these older group, if they don't make prompt clinical response, then you would extend their therapy. So a brief note on steroids. So this is sort of one of the great unresolved controversies in pediatric infectious disease. So I'm not going to weigh in on the quality of the evidence, but just say what the recommendations are. So there is clear evidence that steroids are beneficial at reducing the rate of deafness in children who have Haemophilus influenza and improve mortality, especially in tuberculosis. However, routine use of steroids in all children with bacterial meningitis in developing countries is not recommended, except for those suspected of having TB meningitis. So what does that mean? I think that there's wide variation in practice standards, but clearly, as in the United States, it's not a practice, a standard of care to give children steroids at the time of antibiotic administration. So if you kind of pull together WHO, American Academy of Pediatrics, and the Infectious Disease Society of America guidelines, who should get steroids, who would benefit, right? So it's TB meningitis, kids believed to have HIV, adults who have pneumococcus. This is the dosing, and again, it has to be done at or before administration of antibiotics, blunting the inflammatory response of bacterial death. All right, we're going to move on and talk about helminths. Again, you'll get multiple different lectures on this, so we're going to approach this from a public health perspective. So you can see that the burden is tremendous in terms of the number, billions and millions of people, especially children in low-income countries disproportionately affected with these organisms. If you look over time in terms of intestinal helminth prevalence, there's a very sharp increase in early childhood. And so by early school age, almost every child in the developing world is probably infected with one of these three intestinal helminths. If you look at burden over time, to the number of worms that those people are infected with, again, those soil-transmitted helminths that you get from eating dirt, essentially, peaks for Ascaris and Trichuris in early childhood, and then presumably as you have better hand washing, better toileting, more likely to not eat dirt, that burden drops, except for hookworm, which again, where skin to soil contact over time leads to an accrual of infection. And this is important because hookworm, which is specifically associated with anemia, right, its peak burden is occurring during women's reproductive years. And again, that secondary effect and impact on infant anemia, neonatal anemia, often sort of puts them at a health disadvantage. So what other kind of complications do we think about? Well, acutely, intestinal obstruction. The most common cause of intestinal obstruction in the developing world are due to large burdens of Ascaris. Trichuris has the ability to give you a dysentery-like syndrome. That is relatively uncommon, but can be seen. Rectal prolapse, again, because of the inflammatory response in the distal colon and rectum of the Trichuris, threading itself into the rectal mucosa can lead to prolapse, and is especially prevalent, rectal prolapse would be especially prevalent in children under the age of 5. Strongyloides, I'm not going to get into in great detail, just remember hyperinfection syndromes can occur many years after you were infected because it has the ability to auto-infect. And then the bigger issue from a public health standpoint is probably the huge nutritional burden that all of these infections put on children that affect their growth and ultimately their ability to learn, their cognition, and how productive they are in their societies. And this is, right, again, multifactorial, where in areas where you have both hookworm and malaria, you have worse anemia, you have worse outcomes. So it's never just one infection, there's always sort of multiple hits at work. Now, if you looked up in a pharmacopoeia, Sanford Guide, whatever, any of these infections, you'll see a potpourri of multi-day regimens for treating intestinal ailments. This, from a public health perspective, is problematic because you've got large burden of disease, and even a 3-day regimen of treatment can sometimes be problematic from an adherence standpoint. So the WHO has developed guidelines, and the website is here. I would encourage all of you to download this document. It makes for interesting reading and is a useful reference, very practically oriented. And it gives guidance regarding public health control measures for all of these infections. And especially talks about single-dose therapy, single-dose drug or mass drug administration using single-dose therapy. So if you look at sort of the burden of infection and sort of the general prevalence, the general recommendation is that if the prevalence of soil-transmitted helminths in a school-age population is more than 50%, which, right, pretty much all of Africa, most of Southeast Asia, and some other select areas in the Americas, then those children should be getting empirically dewormed 2 to 3 times per year. Right? So this is one of the rationales for why in MedCaps and MedReadies and those sort of activities that sort of mass drug administration to kids is sort of a knee-jerk thing that you can do that you know actually aligns with international guidelines and is going to have some benefit. So how is it dosed? So for albendazole or mebendazole, there's these single-dose regimens. Again, obviously most of you know mebendazole, no longer made in the United States, no longer available in the United States. The price of albendazole has gone up astronomically as a result. But on the international market, both of these drugs will be readily available at low cost. And is the preferred regimen compared to, say, parental pamoate or some of the other anti-helminthics. For praziquantel, for schistosomiasis, as well as ivermectin, there's actually sort of a Roslow-Tate equivalent for children and adults, where the number of pills you get is driven by how tall you are. And so again, you don't need to know how much someone weighs. You can just have them walk up against a measuring tape that's been coded off. You can see that here, how many pills, 1, 2, 3, 4, and know what their dosage should be. So a note about single-dose therapy. If you compare albendazole, mebendazole, and parental pamoate, right, mebendazole and parental pamoate, which really are luminal agents, for ascaris, right, they're all pretty good. For trichuris, they're all probably equally not so great, single-dose therapy. So if you're specifically targeting trichuris, multi-day therapy would be preferred. But for hookworm, albendazole offers a clear benefit to mebendazole and parental pamoate. And again, so if you're working in an area where hookworm is prevalent, i.e. most of South and Southeast Asia, most of Sub-Saharan Africa, using albendazole will give you more bang for your buck in terms of efficacy and sort of what you're targeting. How is this employed, right? There's a lot of different ways to reach children for these campaigns. Oftentimes, it's going to be integrated into either routine health services, vitamin A distribution programs, vaccination programs, etc. And so, again, if you're going to be working in these environments, it's worth knowing, sort of getting a sense for like, how is vitamin A administration handled in country X? How is mass drug administration of worming deworming handle where you're going to go, and then get a sense of whether or not it makes sense for you to bring that with you if you're doing population, local population therapy. All right, in the final 10 minutes or so, I'm going to try and pull all of this together and give you a tool that even if you forget most of what I've already talked about, again, has a couple resources that I would encourage you to access and put onto a hard drive, print out, and just know that it exists. So the first resource is something called Integrated Management of Childhood Illness. And so IMCI is a system developed by the WHO, implemented by ministries of health, local facilities, and a community approach that emphasizes pre-hospital care in the resource-limited setting provided by people who have limited medical training. So this is really oriented at community health workers, nurses who do algorithm-based clinical care, which is the most common point provider of medical services throughout much of the developing world. And so it's sort of an algorithm-based approach. And the idea here for us, what I would say for us, is that A, it provides a minimum standard of care that you should ensure that if you're providing care to a local population, that if you can't do this, you should probably reevaluate whether or not you're providing any medical care. Because if the community health worker can do more than you, that's a bit of a problem, right? It will also allow you, for those who's done a MedCap, MedReady, where everyone in the village shows up, whether they're sick or not, to come see the American doctor. All right, so a few of you. So you know that in those situations, kind of triaging who actually needs to be seen by a skilled health provider and who doesn't, actually that's a big issue. And so IMCI can also be used as a framework with your medics, nurses, whoever, to help give you a little bit of triage capability, where you can put in place some evidence-based public health measures and then set aside people who might need your attention. So why do we have IMCI? Well, one of the most important things is that in addition to the overall paucity of quality pediatric education and training in many parts of the world, there's also a recognition that unlike what we teach in the United States, where it's always like, give me the single unifying diagnosis, stop giving me the 10 unrelated diagnoses that you're trying to give to your patient. In this context, we know that children often have multifactorial health problems, and so an integrated approach to systematically make sure that we don't get distracted by the most acute health issue and then miss the big picture is important. And so the way IMCI is structured, one is you basically assess for something called danger signs, and then there's a symptom complex oriented approach focused on cough, diarrhea, fever, and ear problems. There's a universal assessment for anemia and malnutrition, and then based on the readily identifiable physical features, you classify based on severity, and then there's specific treatment recommendations to follow. There's a prevention component regarding assessing for immunizations, vitamin A, and deworming. There's some educational components and tools, and this is appropriate also in the context of high HIV prevalence. And so it sort of works really kind of wherever you are in the world. So how's it structured? These general danger signs. These are, right, this is like med student 101, like, is the patient seizing? No, okay, we'll move on to step 2. It's these sort of things which really sort of imply that the outpatient medical care setting is not appropriate, and you need to elevate to a referral system. But then it focuses on major common health problems. And so each country that you work in may have just the standard WHO document, but many of them will have country-specific IMCI algorithms that at 5 minutes on Google will help you find right? The IMCI standards for Iraq, which you can find, or the IMCI standards for, you know, fill in the blank country. And so it's something that I would encourage you to look for. The way they're generally structured is, again, almost like a Broslow tape, where you look at these signs and symptoms, there's specific questions to ask for, physical assessments to look at, and then based on what you observe, you're able to classify into, you know, in this case for cough, you know, you have a cold, you have pneumonia, or you have severe pneumonia. And that's really being driven not so much by the need for an x-ray or even the use of a stethoscope, but just whether or not a child's tachypnic or not, whether there's retractions or not. So again, am I saying this is optimal therapy? No. But if you don't know how to take care of children and you suddenly find yourself having to do that, or you're working in sort of where you have a high volume patient, you know, flow issue, this will help you provide a minimum standard of care. So same thing for diarrhea. Lets you sort of get an assessment of assessing whether a child has none, some, or severe dehydration. Gives you, if you follow this algorithm and read through the flow chart, it'll talk about fluid volume, how much ORS prescribed based on a child's size, and give you that structure that you may need. It'll also talk about, you know, fever, right? If it really gets you thinking about, are you in a malaria endemic area, yes or no? Do you have access to an RDT, hopefully, you know, to make that diagnosis of malaria or no malaria? Assess whether or not you might be dealing with measles and what to do if you have it, if a child has it. Ear problems, same thing, right? And anemia. So for anemia, assessing for anemia by WHO standards at the community health worker IMCI level really means put up the child's hand, put up the mother's hand. If the child's hand is paler than the mother's hand, the child has anemia, right? Is that sensitive? No, but it's certainly highly specific. And so again, gives you some framework of who may benefit from supplemental iron therapy and sort of a nutritional assessment. There's recommendations regarding assessing for acute malnutrition. Again, I think you're going to get a dedicated talk on this. And this will talk about mid-upper arm circumference or weight for height, weight for length systems. Those tables exist in the IMCI handouts. So it will give you that resource. And then, again, it talks about how to manage that from a therapeutic standpoint, typically using ready-to-use therapeutic foods, which, again, are beyond the level of this talk. There's, in each country would have a specific, this is the local, you know, the national standard for vaccinations. There would be country-specific recommendations regarding the most appropriate antibiotic. So again, I'll point out, so the medicines in IMCI are sort of battalion aid station Role 1 friendly. They're typically pills, and they're going to be shelf stable, and they're going to be low cost. So much of what you would already have in your, you know, rucksack or your aid kit is going to match what IMCI is recommending. So whether it's, you know, Bactrim or Cipro, right, these are all medications that are readily accessible to us. And I will point out that, right, so there is a tablet-based dosing recommendation for children under the age of 6 months. So unlike in the United States, where 15-year-olds routinely tell me that they can't swallow a pill, not going to be a problem in the developing world. And if it is, parents are going to be comfortable breaking a pill, crushing it, mixing it with something, and giving it to a kid. And so again, you don't need to worry about, do I have, you know, a antibiotic solution, syrup. There's dosing based on pills readily available. That includes antimalarials, right? So it's all right there for you. Vitamin A doses, mebendazole dosing, and then again, ready-to-use therapeutic foods. So these are like packets of, you know, protein, carbohydrate, micronutrients, flavored packet. And so you're basically, based on the child's weight and whether or not if they have severe malnutrition or not, there's a dosing recommendation about how many packets per day should they be consuming, in addition to any table foods that are offered. In the final 5 minutes, I just want to touch on this half of the all-cause mortality. Yeah.
Can I ask a quick question? How do these standards line up with the SPHERE handbook? The integrated standards, like who developed those and did they incorporate the SPHERE handbook standards? It looks like there's some.
So IMCI predates, so Integrated Management of Childhood Illness predates SPHERE. SPHERE originally, so for those of you who don't know, SPHERE is an international consortium that was the WHO, international NGOs, and large donor countries who came up with practice standards for post-disaster settings. Most of the SPHERE standards are not they're not clinical dosage kind of recommendations. They're much more higher level programmatic recommendations. And I will argue that the people who are involved in SPHERE are, if not they themselves, are coming from organizations that promulgate the clinical recommendations that you see in IMCI and other WHO standards. So I know that really answers your question.
Yes, sir, it does. Thank you.
All right, so another approach, something called Helping Babies Breathe. So this is a program developed by the American Academy of Pediatrics, recognizing that the majority of children in low and low-middle income countries are often delivered at home or with otherwise suboptimal access to high-quality, well-trained clinical staff. And so the idea here is trying to push down additional skill sets, down to community health workers, midwives, and really anyone involved in obstetric and sort of neonatal care. So, and it's basically, you can think of it as a low-resource, appropriate approach to the NRP, neonatal resuscitation program. And so what it realizes is that, all infants, sort of need, you just sort of get the basics, like warm, dry, stim, and that's all you need, right? That's the majority of babies. And where this, right, so warming and drying, kind of that stimulation, in children who have early levels of hypoxia and apnea, that stimulation will get them out of apnea and get them breathing again. And so just teaching people to do that consistently will have sort of a major impact on an estimated 10 million births per year. And then the level of interventions going down to positive ventilation, chest compressions, et cetera, right? That's rapidly shrinking numbers of children. And so the idea here is what can we do to work in the middle range to have the biggest impact that actually doesn't require a lot of specialized skills or materials. So to take you back to your pediatric rotations, a reminder that if you decrease the PO2 in a neonate, you will initially get this sort of episode of primary apnea, which is readily recoverable from if you stimulate the infant, and then you'll get secondary or terminal apnea, at which point positive pressure ventilation is required to bring back the PO2 and get the child breathing spontaneously again. And so this is a Helping Baby Breathe kit. They are made for different parts of the world, so you will have ethnically appropriate, culturally appropriate materials and teaching aids. So not just, I'm not just talking about the color of the baby, but also sort of the images in the teaching materials. So flip charts that can be used to teach these courses to health workers. And so the whole idea here is sort of both teaching routine care and getting consistent clearing of the airway, drying, recognizing sort of signs and symptoms of primary apnea, and sort of realizing that that alone will do tremendous good for the benefit. And then also getting attendants to recognize that primary apnea and to really sort of move into clearing the airway, stimulating, and really doing what's necessary to avoid secondary apnea. And then there is some, and then we also train for initiating positive pressure ventilation. And so the materials that are included in this, the way this is typical in this box, most of the programs that I have seen will sort of work with the health system to make sure that health attendants have access to a durable, reusable, cleanable for a low resource context bag valve mask that can be used. And so Dave Stagliano, a colleague of mine at Walter Reed, when he was in Afghanistan, taught helping baby breathe courses to male midwives in Afghanistan and sort of other traditional birth attendants in Afghanistan. And that was done in conjunction with the Ministry of Health and USAID. And so this is something that a lot of different organizations are employing around the world, including the US military. So again, I would put this into the category of if you're ever given the mandate by a commander to do some good, right? Like know that there are sort of resources out there that sometimes educational, whether they be supporting IMCI training, supporting programs like Helping Babies Breathe, is probably a good starting point for expanding local health capacity. And I think with that, we're about out of time, but I'll stop and take any questions that are pressing from the group, and I'll stick around for the round.